Top Bed Talk.
Hello, my name's Mike Swart. I'm talking to you today from Torbay Hospital in South Devon, United Kingdom. So today I'd like to talk about access to critical care for high-risk surgical patients. Before going any further, I probably should declare a potential conflict of interest. My hospital has a pharmaceutical unit that manufactures metaraminol and sells it widely around the UK and the rest of the world. I'm not sure if this is declaring a conflict of interest or blatant advertising. I'd like to reassure you that all profits go back into the UK NHS. So my talk today is in three parts. First of all, a bit on variation in access to critical care and behaviours in decisions on use of critical care. Then I'm going to move on to describe some of the things we've done in Torbay over the last 20 years to improve access to critical care. And finally, I'm going to summarise on where I think we've got to today. So variation and behaviour. This is a slide showing the variation in number of intensive care beds per 100,000 population around the world. Australia and New Zealand weren't in the table, so I've added them in, with Australia at 9 beds and New Zealand around 6. Now, what you can see is there is big variation. Now, part of this may be due to the description of what an intensive care bed is, but I think it is a clear indicator that equity of access is not the same around the world. And the UK sits at about 6.3 beds per 100,000, with Germany at the top. There's also variation within countries. I've got a role in something called Getting It Right First Time with a colleague, Chris Snowden, up in Newcastle. And we're doing the perioperative medicine theme for this. And it's involved us going around England, visiting over 70 hospitals. And what's absolutely clear is there's wide variation in what access patients have to post-operative critical care after surgery. Examples where access is good are the Royal Surrey Hospital in Guildford and a UCH in London. Now, I'm not criticising them by having good access. I think they have the access that the rest of us are envious of. But why they have it and others don't is a complicated and interesting topic. There's also variation in decisions on who would go to a post-operative critical care unit. If we used mortality, you would expect some consistency across surgical procedures, but that doesn't exist, and it hasn't changed that much over the last 20 or 30 years. For example, elective coronary artery bypass grafting has a 30-day mortality that is under 2%, whereas an emergency laparotomy has a 30-day mortality of over 10%. Now, nobody would start cardiac surgery without a post-op critical care bed, but many of us have to start emergency laparotomies without that luxury. I'll give you another example locally in Torbay. We've developed a post-operative form of HDU for elective hip replacements if their predicted 30-day mortality is between 1% and 3%. Now, that's for the electives. For hip fracture patients who have the same operation but have a much higher mortality, we don't put them in this critical care or HDU facility. And in fact, they leave the same operating theatre, go down one corridor and either turn left to the HDU or right to the normal ward. So that's elective surgery goes left and emergency surgery goes right. Now, if I spoke to the public about this, I think they would find this rather odd. Another example of variation around the country is in vascular surgery. For example, some places, all endovascular aneurysm repairs, or EVARs, and carotid endarterectomies will go to HDU, whereas in other trusts or hospitals, they go to recovery for an extended period of time and then back to the normal ward, unless there is a complication in the first few hours following surgery. So, what have we done over the years about this? First of all, I'd like to ask, and usually at this point I ask people in the audience to put up their hands, but clearly that's not an option. But I'll still ask the question, how many of you have read a randomized controlled trial on HDU care after surgery? My experience in asking this question in the past is not many hands go up. There is one. It's from Torbay. A number of years ago, we used an anaerobic threshold of above or below 11 as a cutoff to select high-risk patients after colorectal surgery. And we randomized them into two groups, those that went to HDU and those that went to the normal ward. And our outcome measures were adverse cardiac events, defined as a myocardial infarction, acute left ventricular failure, or a cardiac arrest. And in this group, the top line is those who are deemed fit and not randomized, and there were no cardiac events. Then in the next two lines, there were 51 patients that went to HDU and 32 to the ward. This was, the randomization was set to do this, and our outcome was 7 cardiac events if you went to the ward and none if you went to HDU. Now, what value is this paper? Probably very little, in that it's achieved very little change in post-operative care. What it did do, though, was teach John Carlisle and myself a little, throughout the thinking we did over this, a little bit about risk prediction. And here's a photo of a younger version of John Carlisle on a cardiopulmonary exercise test. So over the time we were doing this study, 3 things happened. We developed, or rather John developed, a risk prediction model for post-operative 30-day mortality. At the same time, we also developed a perioperative medicine clinic that used or developed shared decision-making for high-risk surgery. We also realized that if you're going to study HDU, you have to first define what it is. So this is the definition that you need to define the reason for going to a high dependency unit. So this is what we came up with. We came up with a plan in Torbay that if your predicted 30-day mortality for elective surgery was greater than 4%, you would go to an HDU bed, and if there wasn't a bed, your surgery would be cancelled. We then had a group with a predicted 30-day mortality between 1% and 3%, who, if there was no bed, you discussed between surgeon, anaesthetist, critical care, whether to proceed or not, and you may or may not proceed, depending on that consultation. And then those with a predicted 30-day mortality of less than 1% were allowed to proceed without an HDU bed. Now, we thought this was a reasonable way to do things because it gave clear definitions to the greater than 4% and less than 1%, but allowed for some variation depending on individual patients or surgical procedures to influence the decision. It did work, but it also had some side effects. The side effects were unhappy surgeons because of cancellations, unhappy managers because of fines from the trust, because of long waits for certain procedures. And it also did cause a little bit of disagreement in that some people didn't believe we were able to do predictions of 30-day mortality and didn't believe there was any evidence for the use of HDU. I think what I learnt from that was when somebody tells you there's no evidence, it means they don't know what the evidence is. So what happened next? We had 2 groups. We'd have people who interpreted the discuss before proceeding as they don't need a bed, and other groups that went, well, if there's a bed, we'll use it. And in the end, the solution that was proposed because of the disruption this caused to surgery was to stop the clinic. The feeling was we made these risk predictions in the perioperative medicine clinic. if we didn't see the patients in the clinic, then we couldn't say they needed HDU care. This unfortunately wasn't true. All that it would mean is we wouldn't have the benefit of seeing the patient, doing a cardiopulmonary exercise test. All we would have is the notes to determine their predicted 30-day mortality, which would have actually increased the demand for HDU care. So there was a meeting with our medical director over this, and a decision was made. Now, fortunately, we had some other evidence about our clinic and decision-making from the clinic and post-operative care. This slide shows a study of 314 patients who had colorectal adenocarcinomas. And these two survival lines are patients referred to the clinic and patients not referred to the clinic. Now, at that time, the referral to the clinic was determined by the surgeon. And if they didn't think the patient was unfit, they wouldn't refer. Now, what we've demonstrated here is in these two groups, you lived longer if you went to see us in a clinic. Now, the probable reason for that is you got HDU care. The two groups were almost identical in terms of cancer and cancer staging. The group that came to the clinic were older, had a higher ASA, and had higher creatinines. Now, the advantage of this study that, again, people are probably not aware of, is it helped us in our discussion with the medical director. We were able to ask the medical director if people who went to his gastroenterology clinic lived longer than those that didn't. He wasn't able to answer the question. Final study I'm going to mention, from Torbay again, is a study that looks at decision-making. Now, I'm particularly proud of this because I don't think we study decision-making. We may study one test over another test, or one drug over another drug, or one operation over another operation, but we don't study the overall decision-making and outcome. So what we did here was we had this cohort of patients who were either in the greater than 4%, the 1 to 3%, or the less than 1% predicted 30-day mortality. The greater than 4 predominantly went to the intensive care unit for HDU care, and the less than 1% went to the ward. And then in the 1 to 3% group, we had some that had HDU care and some that didn't. And I'd like to show you the results of that study. Now, this at first looks a bit complicated, but if you just start looking at this as a flow diagram going from left to right, on the left, you have patients seen in a clinic who are given a predicted 30-day mortality based on age, operation, comorbidities, and an exercise test. They're then put into 3 lines, greater than 4% who go to HDU, 1 to 3% who could go HDU or ward, and less than 1% who predominantly go to the ward. Now, if you look at the top, at the red, of those that went to HDU who were at the highest risk, 4%, the figure of a surgeon means they went back to theatre post-operatively. The figure of a bed is they returned for an unplanned ITU admission at 9%. And then the final figure is the cost per patient that we estimated. Looking at the middle yellow, HDU or ward, of those that went to the HDU, nobody went back to theatre and nobody had an unplanned visit to the intensive care unit. Of the yellow line that went to the ward, 10% went back to theatre for things like an anastomotic leak or a collection, and 16% had an unplanned admission to ITU. Now, what I think we demonstrate here is an assessment, a decision-making, and a process, not just one option, result in a different outcome. And finally, it's not more expensive. Your excess intensive care costs outweigh your high volume but lower cost HDU costs. So what have we achieved over this time? This may look a little bit depressing. We have 2 what we call level 1.5 beds for enhanced care for orthopaedics. The reason we had them for orthopaedics is the cancellations that were costing the trust were in orthopaedics and not colorectal surgery. But I still think we have achieved something. It's been running for, in a few weeks' time, because we started in June, it will be 4 years. And what did we do? We used arterial lines, arterial lactate measurements, metaraminal for hypotension, magnesium and amiodarone to treat AF post-operatively. And we did this on an enhanced ward. So it was 2 beds on the normal orthopaedic ward, backed up from the critical care unit. And it's worked. We haven't had complications, we haven't had cardiac arrests. Our only unplanned admissions to ITU, or almost all our unplanned ITU admissions, are because it closes on a Saturday. We've also learnt it's not just about the arterial line and the metaraminal. It's about the whole care. And starting at the bottom, it's about providing an environment that has shelter, warmth, food, private access to toilets. Now, these things are not normally available in an intensive care unit. We also need access to Wi-Fi these days to communicate with friends and family. It needs to be a quiet, calm environment. And again, I don't think an intensive care unit covers that. It also needs active involvement from physios, OTs to do the enhanced recovery bit. We were finding in the intensive care unit, if you went there, they didn't get you out of bed because the priority was the sicker patients. Also, visitors. Visitors find the environment of an intensive care unit more intimidating than that of the normal ward. Finally, going to come back to behaviour. One of the problems in developing this has been in behaviour or attitudes that within intensive care, the emphasis is on sick patients. And I'm talking particularly about UK intensive care. And once somebody's well enough to not need a ventilator, they are discharged. Once somebody no longer needs vasopressors, they are discharged. Also, you don't admit them until they need them. Whereas in our enhanced care area, we were finding that 40 to 50% had an intervention that they couldn't receive on the ward, but 50% were not needing it. But if you follow the ITU admission criteria, you would not get considered for admission until you develop the problem. And then the problem can't be treated until you're transferred to the intensive care unit. Now, these behaviours, I think, are intrinsic within how you are trained in intensive care medicine and also part of the behaviour of people who work in intensive care units. And I have to state, my background is in intensive care. I think this is one of the most important papers I've read in the last few years. And what it highlights is the gender disparity within consultants in UK intensive care units. And I think with that comes behaviour change, differences in behaviour. The focus on the high risk, the complicated, the complex, the clever machines, the clever drugs, that's the interesting bit. Whereas the HDU bit, a lot of people from intensive care are not really interested in that. Finally, I'd like to end on, this is probably the biggest achievement. This was published in May 2020 from the Faculty of Intensive Care Medicine, where finally we've written down some guidance on doing something that is in between the intensive care unit and the ward. And that will be part of another talk by Anna Batchelor in EBPOM 2020. Thank you very much for listening and watching.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.